Okay, I'm going to go ahead and start with the basic examination of the lumbar spine. And so what I want to do, and this is the same thing that I'm going to do with every single joint system, is I'm going to try to perform the least amount of testing to get the most amount of information that I can. And so one of the primary things that I'm going to do, again, with every single joint system is to look at whether or not there's a limitation in motion. And for the lumbar spine, it's no different. I'm going to look at whether or not there is a limitation in lumbar spine motion, and in particular, whether or not the person has a limitation that's consistent with the capsular pattern limitation. The capsular pattern was originally described by Syriax as being a repeatable, reliable pattern of limitation that's unique to each joint system that's associated with degenerative joint problems or inflammatory joint problems. And so it's really a critical part of trying to determine what direction I'm going to go with my patients, and especially if it's a younger patient, I should never see a capsular pattern limitation. So for the lumbar spine, the capsular pattern limitation is extension is severely limited, followed by equal and symmetrical mild limits of side bending and no limit of flexion. And so what I'm going to start off with in this case is I'm going to look at left side bending. And so what I tell the patient to do is let his hands flat onto your thighs, and what I'm going to do is I'm going to guide him through that motion. And so I'm going to have you just go ahead and bend towards your left as far as you can go, and then basically what I'm looking for is the amount of motion that he has and whether or not there's any pain provocation with that motion. I'm going to go ahead and switch to this side, and I'm going to do the same thing. I'm going to guide him through right side bending, and again looking for the amount of motion and then whether or not there's any pain provocation with that motion. The next motion that I'm going to look at is flexion. I'm going to have him turn this way, and then I'm going to have you reach forward as far as you can, and looking at whether or not the lumbar lordosis is reduced with that motion, also looking at how far he can bend as well as whether or not there's any pain provocation with that motion. The final motion that I'm going to look at is extension, so you can turn this way, facing that way, put your hands on your hips, and then I'll look at extension. Really important to look at extension, again, because in the lumbar spine, extension is the most limited in a patient who has a capsular pattern limitation. Okay, I'm going to go ahead and continue the examination with the patient positioned in supine. What I want to be able to do is look at all of the tests that I need to look at in standing, and then try to go through as much stuff as I can in supine, and then finish up in prone. That way I'm not having the patient switch back and forth. What I'm going to look at first is hip range of motion, and I'm interested in 3 motions to try to determine whether or not the patient has a capsular pattern limitation in the hip. Again, the capsular pattern is interpreted as being a limit that's caused by either inflammation of the joint or degeneration of the joint. And so the motions that I'm going to look at are flexion, internal rotation, and external rotation, with the capsular pattern consisting of limitations in motion where internal rotation is the greatest limit, followed by flexion, and then the least limited is external rotation. So again, I look at both sides, comparing left to right. I'll go in and look at internal rotation. There's my internal rotation. If I need to, I could switch to the opposite side, but for the sake of the video camera, I'm going to stay on this side, and I'm going to look at internal rotation. Again, trying to keep the hip in as neutral of a position as possible. And then the final motion that I'm going to look at for the capsular pattern of the hip is external rotation of the hip. So I'll look at external rotation on the left, and I'll compare it to external rotation on the right. Again, looking for limitations, and of particular interest is a limitation in the capsular pattern, an indication of either inflammatory condition at the joint or degenerative condition at the joint. The next thing that I'm going to look at is resisted hip flexion, which is corresponding to the L1, L2 nerve root. And again, I'm going to have him just raise the foot up off the table and get a nice hold and relax. And if I need to, I can switch to the opposite side of the table, but I think I can do it on this side. Go ahead and push against me, getting a nice strong isometric contraction and get a comparison from side to side. I'm going to go down to the feet, and I'm going to look at resisted ankle dorsiflexion with inversion, which is the anterior tibialis muscle, which is a really important muscle to look at because that's an indication of weakness at the L4 myotome. So go ahead and push your foot up and in towards my elbow. Good. Hold, hold, hold. Good. And what I'm going to do is I'm going to come around to the opposite side and that comparison again. So what you're going to do is you're going to pull up and in and hold, hold, hold. A nice strong isometric contraction. The next one that I'm going to look at is plantar flexion combined with eversion. This is going to test the perineal muscles for the L5 S1 myotome. So go ahead and push down and out. Good. Nice strong isometric contraction. Then I'm going to come around on the opposite side, push down and out, push, 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 push. Good. A nice strong isometric contraction. The third muscle that I'm going to test down here in the distal end is going to be the great toe extensors. This is L5. So go ahead and push back against me, push, push, push. And then I'll get a comparison from side to side. Push back. Good. The other thing that I can look at here in the supine position is the Babinski reflex, which for lumbar spine pain, this should always be negative because this is an indication of an upper motor neuron problem. And what I'll do is I'll bring the reflex hammer along the plantar surface of the foot to the metatarsal heads and then bring it medially. So I'll do it really quickly. And what I'm looking for is a extension of the toes and splaying of the toes as a positive for an upper motor neuron lesion. So, negative. The other thing that I can look at in the supine position is the patella tendon reflex. And again, a nice brisk reflex there, and I can do the same thing on the opposite side. So relax. So, okay. Now what I'll do is I'm going to have you go ahead and lie on your stomach for me. I can look at hip extension. So I can have him, what you're going to do is going to raise the whole leg up off of the table and push up against me. Good, and relax. Hip extension on the left. Go ahead and push up against me. Good. I can look at S1, S2 for knee flexion, testing the hamstring muscles. Go ahead and push back against me. And then I can compare to the opposite side on the left side. Go ahead and push back against me. I can also look at knee extension. So go ahead and push down against me. Again, testing the myotome that corresponds to L2, L3. Go ahead and push down. Good. The other thing that I can look at in this position is the Achilles reflex. I'm going to go ahead and put the heel cord on a little bit of tension, and I'm just going to give a nice tap on the Achilles. I'm looking for a nice brisk reflex, and I can look at that bilaterally. Good. And an additional test that you can do on a patient, especially a patient who has low back pain with leg symptoms, is a nerve tension test. And we're going to use the straight leg raise test to try and determine whether or not the patient has a positive nerve tension sign. And the procedure for that is, the first thing that I'm going to do is I'm going to maximally dorsiflex the ankle. So I'm going to bend the knee and then relax, and I'm going to maximally dorsiflex the ankle as much as I can. So I take up all of the slack in that position. Then I'm going to lower the leg down and get the knee completely straight while maintaining that ankle dorsiflexion, and then I'm going to bring the leg up. So there's my straight leg raise. And what I'm looking for is reproduction of the patient's symptoms. At this point, they would say, that is my pain, that's where it hurts at down in my leg. And so what I'm going to look at for a positive tension sign is decreased pain when I let go of the ankle dorsiflexion. So again, the sequence is reproduction of symptoms with the maximal tension position with the leg, the hip flex, knee extended, maximal dorsiflexion, with decreased pain with relief or release of the ankle dorsiflexion.